We shall go on to our next speaker, Dr. SWATI Upadhyaya, who is a medical consultant glaucoma services from Arvind Rai Hospital, Pondicherry. And she's going to tell us about CAT and the tips on case selection and surgical technique. And I think it's getting more and more popular. So we look forward to hearing from you.
Thank you, ma'am. Thank you so much for this opportunity. I hope my slides are visible.
Yes.
Yeah. So I'll be talking on tips on case selection and surgical technique for achieving best results. So as we all know, gonioscopy-assisted transluminal trabeculotomy is the brainchild of Dr. Davinder Grover and Dr. Ronald Feldman, and they came up with this technique in 2014, which involves cannulating 360 degrees of the Schlemm's canal by passing a Prolian suture or an eye-track microcatheter, creating a 360 degrees trabeculotomy. Prerequisites for any mix are sound knowledge of the angle anatomy, suitable surgical gonio lenses, both direct and indirect, mastery over direct and indirect intra-op gonioscopy, which means patient and microscope positioning, tiltable microscope, mastery of microscope foot pedal, and ambidexterity and patience. The preoperative test for suture GAD will be, first is a patient selection. So who are the patients who are really, you should take up when you are starting GAD? These are the mild and moderate glaucomas, POAGs, pseudoexfoliative glaucoma, pigmentary glaucoma, and ocular hypertension. So which gonioscopy would I, if a patient is having an angle like this, where all the structures are clearly visible, the scleral spur is the most important landmark. If you can see the scleral spur in the nasal angle, these patients are the first to try on. In contrast to these type of angles which are like not having a clear-cut demarcation of the scleral spur, the iris pigments are dispersed throughout. So these should not be the first ones to be selected. So please select clear-cut cases where scleral spur is clearly visible. So before you start, you should do intra-op gonioscopy. You should practice intra-op gonioscopy in your routine phaco cases. So for that, you need positioning. So turn the patient's head 35 degrees away from you and tilt the microscope 35 degrees towards you. Use a high viscosity cohesive viscoelastic. Either you can have Helon GV, and if Helon GV is not available, then you can have Oro gel, which is also 14 milligram per ml viscosity. Now the patient positioning at the table positioning is very important. You should have the table in a slanting reverse Trendelin works position, so that the head of the head of the patient is above the heart level. So tilt the OT table so that the head end gets elevated. How this will help? It will prevent blood reflex from the Schlemm's canal. So this is the way we should keep our OT table. And also preoperative counseling is very, very important, because most of the patients, or maybe I would say more than 50% of the patients, might have hyphema. So this is a video showing intra-op gonioscopy with a Swan-Jacob gonioprism. So you put OVD or a cohesive viscoelastic on top of the cornea. After proper patient and microscope positioning, you put the lens in your non-dominant hand, so that in the dominant hand you can have the MSD forceps. So this beautifully you can see the angle structure, the scleral spur. And this will improve, go on refining as you practice intra-op gonioscopy. So the intraoperative problems or complications which can face is either they can be bleeding from the Schlemm's canal. The moment you give a nick or the limited goniotomy, you can have bleeding from the Schlemm's canal. You can have a non-advancing suture. You can have a false passage and your suture keeps on going and it doesn't appear from the other side. So you must suspect false passage. Shallowing of anterior chamber can also happen. So my tips would be, to reduce bleeding from the Schlemm's canal, you should have head above the heart, as I showed. Lift the head end of the operating table. This will reduce reflux from the Schlemm's canal and the collector channels. Use high viscosity OVD. Now to avoid false passage, what we should do, we should first use intracameral pilocarpine so that the iris constricts and the angle structures are clearly visible. We should have proper understanding of the angle structures. We should not confuse trabecular meshwork with ciliary body band. Blunt the tip of the 50 Prolian suture into a little mushroom, as you can see on the left hand side, as compared to the right hand side suture, which you can see it's a very large bulb. So if you have a very large mushroom at the tip, it can easily create a false passage. So it should be just the blunting of the tip. The limited initial goniotomy should be just 1 clock hour, so that you don't open the all the visible nasal angle. So then what will happen is, when you do a limited goniotomy, you will see the suture being fed into the Schlemm's canal and you can see it through the trabecular meshwork. Then confirm the suture in the Schlems canal while doing the initially when you feel that you have done 90 degrees of GAD, or you have proceeded 90 degrees. Take an indirect gonial lens, put it onto the cornea, and see confirm. So the arrow showing there is that the suture, the blue color is seen through the trabecular meshwork, and you can find that yes, my suture is in the Schlems canal. I can see the scleral spur below my suture. So in the second picture, you can see that half of the suture has reached halfway, and the halfway it has not reached. So you can still confirm that yes, I am in the Schlems canal. What about a non-advancing suture? So always pre-measure the suture, just make a loop around the cornea and just have a rough estimate. Okay, this much suture I'll be needing, and kink the 50 proline at a place where, okay, you just have an estimate that yes, this is a suture. If the kink appears, then definitely, and my suture hasn't appeared from the other side, then definitely I'm in a wrong place. Confirm the suture present in the Schlems canal, as I already told. If from one side the suture is not proceeding, then you can switch to a twin side, or just try feeding the suture from the opposite side. So if you are doing a left eye and you have started from the superior side, if the suture is not proceeding, then you can make an inferior paracentesis and then start feeding the suture from the opposite side. Resistance will be felt at 180 degrees, which is a good sign. What about having a shallowing of anterior chamber while doing intraop and GAD? So use high viscosity OVD, Hilonjivi or Orogel, as I told, so that the anterior chamber is well formed throughout the surgery, and do a gentle placement of the gonial lens, and you should not have folds in the cornea. If you're pressing too much with your non-dominant hand onto the cornea, you will have Descemet's folds, the corneal folds. Now, what about the post-operative complications? Hyphema. You can have a varied variety of hyphema. If you're lucky enough, the patient will not have hyphema on POD1, but you can have diffuse microhyphema, or you can have a layered hyphema. So we don't have to panic if we have counseled the patient well off before surgery that yes, some amount of bleeding will be there because we are opening the 360-degree channel, and you should not panic. Within 1 week, the blood will resolve. And always we have to ask the patient to sleep on the side of surgery, so that whatever hyphema occurs, it will accumulate on the temporal side, and the nasal angle, which has the maximum collector channels, will still be open. So we have to remember to tell the patient to sleep on the side of surgery, which is very, very important. So if you have hyphema, preoperative counseling, discussing possible risk factors with the patient and one caregiver is very important. In the end, when you have completed GAD, just fill the anterior chamber with Hilonjivi or Orogel. Leave 30%, like 30% filling of the anterior chamber can be done with Orogel. And believe me, this will not cause high intraocular pressure post-operatively. And even if the pressures are little on the higher side, we can use alpha agonist BD dosage for 7 days. And also we can use pilocarpine BD for 7 days. Most of the hyphemas are self-resolving and they disappear in 7 days. What if you have a choroidal detachment due to a false passage? Then this is the first day post-operative period, which in a patient which I had false passage, and I could realize on the table itself that my suture is going in some other direction. So I retrieve my suture back, again reassess the angle anatomy, again reassess my maneuver where I'm putting my suture. Then I fed it from the opposite side, and then I had a 360 degrees successful GAD. So the patient was put on systemic steroids in tapering doses, and also topical steroids were continued. And this is the post-operative day 15 that CDs had resolved completely and the patient had 6/9 vision. These are some of the pictures what you see in a post-operative period in a gonioscopy.
And 1 minute remaining.
So you see a cleft like this. These are the white, this is the white wall. The sclera is seen because you have removed the trabecular meshwork covering the Schlems canal. So this is a cleft which we normally look for, but we can have surprises in the form of small pars, peripheral anterior synechia, but these pars are not extensive. So we don't convert an open angle into a closed angle, as many people think that we are converting an open angle into a closed angle, which is not the basic actual reality. Sometimes you can have still blood oozing from the Schlems canal, as you can see from on the left hand side, on the right hand side picture. Small blood clots or small oozing from the Schlems canal will be there, and if you make the patient hypotonous, then you can see the blood reflex directly. So my take home messages will be the 10 commandments. Select moderate open angle glaucoma cases to begin with. Use widely open angles on gonioscopy. Do a very good preoperative counseling. Practice intraop gonioscopy on your routine phaco cases. Don't make large initial goniotomy, just 1 clock hour is enough. feed the suture in the Schlemm's canal, don't push it. So when you put this, feed it into the Schlemm's canal, it will very nicely take its path and come from the opposite side. Keep the head above the heart to the table tilt. Use liberal high molecular weight OVD. Use indirect gonal lens to confirm suture position, and be patient and perseverant. I would like to thank my mentors, Dr. Venkatesh and Dr. Davinder Grover, one to make me take this path of MIGS and one to teach me GAT and other MIGS. Thank you so much.
Yes, Dr. Swati, that was an amazing talk. I had an opportunity to hear you in GSI and I knew you would be excellent. We are not going to take questions. We need to do justice to the next three speakers. So just stay on. We'll do some panel discussion.